Hello, I am Thomas Farrington, the president and founder of the Prostate Health Education Network, and I am pleased to welcome you tonight for the special webinar. I also want to thank our audience and our partners and sponsors for being with us tonight. This is the first in FIN series of patient treatment education and empowerment webinars. This is an important area that we spent a lot of time focusing on, and we're just so excited to bring you this webinar this evening. I was diagnosed with prostate cancer in March 2000, and I've been on my prostate cancer journey for 21 years now. Just this month, I had my 21st birthday, so you might say that I am now an adult prostate cancer patient in terms of the years that I've been on my journey. When I was diagnosed, I was frightened. It is the same for most all men when they are diagnosed with prostate cancer. You immediately grip with fear. But even in that fear, you have a job. You have a job that you have to do. And that job is to find a treatment that you think is the best treatment for you based upon your condition at the time that you are diagnosed. But you know, like most men, I was totally unprepared for that chore, to find a treatment. I was just learning about my prostate and trying to understand my condition, but I was really forced into a position of looking for treatment options. I did not have a treatment GPS to guide me, but I had to rely on my research, and I did this and began treatment 5 months later. Those were very, very trying times. I can't explain to you the consternation that I went through, the many nights that I was up reading and walking through documents and data. That was very hard to even evaluate the information that I was studying. So 20 years later, I was pleased to develop FinPath.com as a prostate cancer treatment GPS to guide patients along their prostate cancer journey. I would have loved to have had this GPS 21 years ago. We're excited to begin the process tonight of educating patients about FinPath and using it to navigate their prostate cancer journey. This is so very important. When you think of treatments will determine your survivorship from prostate cancer and your quality of life. And there's so very many treatment options that are there all along this journey. And you're faced with making decisions all along. So my decision wasn't just 21 years ago, but I've had to make many other treatment decisions during this 21-year period. So I have been faced with this, understand very well what's required in that process, and know the challenges, that prostate cancer patients face. So again, we are excited to bring you this program tonight. It's the beginning of a series that we will continue throughout 2021. And my goal, our goal at FIN, is to have prostate cancer patients, number one, understanding how to access the information to help them make treatment decisions along their journey, and to provide them with this tool. That's our goal. If we can do that, we think we can have a tremendous impact on prostate cancer survivorship. One of the issues that we know with the African American prostate cancer disparity is that the treatment disparity is a factor in the overall death rate being more than twice that for all other men. We can address this treatment disparity with FinPath, and by doing so, we will hope and expect to reduce the overall prostate cancer racial disparity. So we're excited to get started tonight, and the program will include a presentation by Dr. Keith Crawford, our Director of Patient Education, followed by a patient roundtable discussion. where they will talk about their journey and what they've learned over the years that they have been prostate cancer survivor. So at this point, I'm going to introduce Dr. Crawford, but I want to let you know that there will be questions and answers following the roundtable discussion. So you can submit your questions at any time during the program, but we will address these questions after the patient roundtable discussion. So enjoy tonight's sessions. I do hope you learn from it. And at this point, I'm very pleased and excited to introduce Dr. Keith Crawford.
Yeah, thank you, Tom. I'm very excited about being here tonight. I'm very excited about what we're about to present when it comes to finpath.com. So again, thank you for attending this evening's webinar series. Now, this is the beginning of our patient treatment educational empowerment initiative, and we'll have a series of webinars that bring up key topics about patient treatment. But a question I'd like to ask, especially with a lot of the prostate cancer patients that are online with us tonight, do you know where you are on your prostate cancer journey? And what about the treatment pathways and the options for prostate cancer? Are you aware of what they are? When people talk about this process, are you lost, confused, perplexed? It's overwhelming. But finpath.com is a new tool that will help navigate you through this complexity of treatment pathways and options. So I had mentioned before, and this is a new initiative that we're moving forward, the Patient Treatment Educational Empowerment Initiative. And we'll have a series of different webcasts. The one that we're doing tonight is treatment and options. But later on, we'll have early detection, the clinical trial rally, and even bone health. Now, tonight, we're not going to focus on everything when it comes to treatment options. We want to give you an overview of treatment pathways. And then what's important is to give you some real life experiences and really at a high level demonstrate how FinPath can help you navigate your prostate cancer journey. So I want to go back again, and I want to repeat some of the things that you heard from Tom quickly. Tom is a 21-year survivor. March 2000, and we're talking about March 21. And FinPath really is a reflection of all men's prostate cancer journeys, their concerns, their challenges at identifying pathways, and most appropriate, what treatment is best for them. Now, Tom designed FinPath to support your needs, the needs of all prostate cancer patients, as we travel along this personal journey. So you'll start to hear words like personalized medicine. This is the first personalized tool for your prostate cancer journey. Now, what did we say earlier? Understanding the patient's needs. Before you can design something, you really need to understand what the patient needs. And to do this, we recognize there are 5 things that the patient really needs. Now, first, current and reliable information. So FinPath incorporates newly approved and available treatments. 2, increasing your knowledge. Now, increasing your knowledge increases the participation, and you'll hear a word being bounced around a lot, shared decision-making. So it improves participation in the shared decision-making process with your doctor. One thing that's extremely important is ease of use. Now, FinPath consists of decision aids, which can help guide you and your family's discussions with your doctor. Now, 4, increasing confidence. If you have 1, 2, and 3, these will increase your understanding of your treatment options. And if they can increase your understanding of your treatment options, now you spend a productive time with your doctor to evaluate your options and make informed decisions. So I said earlier, the new word, the new term is shared decision-making. Now, in the past, your clinician here on the left would make a diagnosis, And then here are the treatment recommendations that he tells the patient. That's it. That's the way it worked in the past. But now, with the informed shared decision-making process, there's a bidirectional interchange between the patient and the doctor. But if you look at the key components of informed shared decision-making, it's the doctor's recommendation and the patient's knowledge. And I say it again, the patient's knowledge. The average patient coming in and being told you have prostate cancer may not even know where the prostate is. So with FinPath, this new tool, that changes. It's a game changer. So now what you have is this bidirectional communication between patient and doctor. So now that we understand what the patient needs, well, how do we address that? Well, we address that by doing what? Creating finpath.com. Now, these are treatment pathways for prostate cancer patients. And what did I say earlier? Number one was reliable information. FinPath is a patient treatment tool based on the National Comprehensive Cancer Network, NCCN, clinical treatment guidelines for doctors. These are the guidelines that your doctor will use when discussing with you. Now, what's nice about it is this. You can either use your computer, your tablet, or even if y'all want to slip away and take a look and see if you can get it on your cell phone, it's there too. So, treatment pathways. You have to choose the pathway that best fits your diagnosis. Now, there are a lot of subcategories and multiple pathways to follow, but what I wanted to do is keep you at a high level. And we've grouped everything into 5 different categories. The initial prostate cancer diagnosis, that's the category, the box, that if you were just told or you just discovered that you have prostate cancer, this is the box in the category that you would go into. Now, if you're a survivor, and again, there are 4 other categories for survivors. For example, if your PSA comes back after surgery, or if you have cancer progression after your radiation treatment, you have advanced hormone-sensitive cancer. So it's the type of cancer. Is it hormone-sensitive or is it castration-resistant? If the present treatments are not working against it. So castration-resistant. This has nothing to do with surgical castration. This is more of a chemical castration. So the take-home message here is this, is that now with the treatment pathways, you can choose what's best for you. So now you're not running around lost, confused, bewildered about your treatment. Now you have the ability to personalize your journey with your wife, caregiver, loved ones. Now remember, you can access this on a mobile device. That gives you the opportunity to sit down in your doctor's office and pull up this important tool to help walk through your treatment options. Now, I said earlier, what was extremely important was, one, to kind of give you a brief overview of FinPath, but I wanted to give you real world experiences. So what we have here are 3 survivors ranging from 10-year survivor to a 16-year survivor, ranging from Texas to Boston and stopping through Alexandria, Virginia. So I'm going to remove it, but I'd like to introduce you to Mr. Dwayne Charleston, Mr. Henry Turner, and Mr. Sherman Womack, who will be joining us by phone. So what I wanted to do, I want to ask you a couple of questions. And that's where I wanted to start it off. So each one of you, I'm going to ask you, and I'll start with Henry. Where did you start on your prostate cancer journey? Yeah. Did somebody tell you your PSA was elevated, your Gleason score, or the stage? And it's a two-part question. And what was your treatment choice?
When I moved to Virginia, we had a new doctor, and I had never had a PSA test done and discussed when I was in Boston. This new doctor did a PSA every 6 months, I think. And in 2006, he informed me that it had jumped from like 1 to 5. And he was concerned that it had moved up so rapidly. He referred me to a urologist who knew nothing about treatment options. All he knew was surgery. One of my friends recommended Tom's book, which I read and found some other treatment options. Discussed that with my primary care guy. He knew nothing. My cardiologist had experience with a couple of treatments, and he referred me to a radiation center in Alexandria. And I should say that I had a friend who had surgery just before I was diagnosed, and he was having a lot of issues with his surgery. That scared me. My brother-in-law had his prostate frozen. I'm not sure of the process, but he went through a lot of turmoil before and after the hospital. He was in the military, and of course he had it done at Walter Reed, so I'm not sure what they really did. When I talked to the radiation oncologist, he discussed the radiation treatments, and he put me on a fast track. So I had 5 weeks, 5 days a week of radiation for about, I think maybe half an hour to 40 minutes. And then the 6th week, I had radioactive seeds implanted into my prostate. There were 126 seeds implanted.
So let's stop right there. So what you're telling me is one, you had an opportunity, your experience was related to your friends around you. So there was a person that had surgery that didn't do well. And
Right.
there's a person and a family member that had a cryo where they froze the prostate. And
Right.
so you elected to do radiation treatment. Now I want to go ahead and ask Mr. Charleston, Dwayne, same question. Where did you start on your prostate cancer journey? And if you know your Gleason score or your stage at the time, tell us. And then what was your treatment choice?
Yeah, in September of 2009, I thought I was having some heart problems, and I was very stressed out over some issues that I was going through, and I thought I was having some heart problems. I went to the hospital, and they called me the next day because I had just taken a PSA test. I had heard of a PSA test and never taken it, and hadn't been to a doctor in almost 10 years. But I took a PSA test, and they called me the next day. They told me that I had some very high scores. I didn't know what that meant. But the next day, they sent me over to MD Anderson, and MD Anderson started explaining some stuff, and they did a biopsy. A few days after they did a biopsy, they gave me the results, and my first PSA was an 86.1. That was the very first PSA. I had a biopsy 16.
And how old were you?
I was 46.
46, okay, thank you.
46 years old. They did a biopsy. I had 16 positive, you call them samples, 16 out of 16 samples came back positive. And I had, it had spread outside of the prostate based on the biopsy. And it was in the seminal vesicles, I think, and some lymph node involvement. And so that was 11 years ago. And so I've done, I had the surgery, radical prostatectomy, radiation therapy, penile implant, urinal sphincter, 6 different surgeries over the last 11 years. So.
Okay. And then, so I wanted to stop there. I wanted to ask Henry, what age were you when you were diagnosed?
65.
65. Okay, now, Sherman, you're up on deck. So again, I'll repeat the question. Where did you start on your prostate cancer journey? And are you aware of your PSA, your Gleason score, or your stage at the time? And what was your treatment choice?
My prostate cancer journey started back in 2004. It was right after my 52nd birthday. I had just gone to see, going for my yearly physical. And 2 days after I got my physical, my doctor called me back and said, something's not right. Your PSA is now 4.1. And I just had got a new physician. The physician before, the year before, my prostate cancer, my PSA was 2.5, and it went up to 3.9 in 1 year. And my primary physicians noticed that and said something should have been done last year. But anyway, after that, I got a little nervous, although I just had a brother who was diagnosed a couple months before that, but getting ready to have surgery. So, but I still wasn't aware of what the prostate cancer thing was all about. So with that, my primary care physician, he gave me a few doctors' names, a urologist, oncologist, and radiologist. By this time, I had already talked to Finn and Tom Furniture to get the idea of what was going on. So with that, I chose to have a radical prostatectomy. And my urologist, and the reason, I guess my main reason was because of the fact that my brother just had gone through it, and I wanted it out. That was my main reason for using the prostatectomy. What was the other question?
And then the question is, so you answered it, and you had a radical prostatectomy. So
yes,
now you have Sherman had a radical prostatectomy, Dwayne had radiation and surgery, and Henry, you had radiation. So I'll keep those up on deck, and I can take
And
you.
the other process was called a brachy.
Yeah. Oh, okay. So yes. So, okay, I got you. Now, so I'll put you in the general category with radiation. Now, the next question, and this time I'm going to start with Sherman. How did you make your treatment decision with your doctor? And right now, or then, were you satisfied with the decision you and your doctor made?
Once again, like I said, I chose the radical prostatectomy because of the fact that my brother had just gone through that. And I just wanted it out. As far as radiation concerned, it wasn't discussed that much with me. And I just know I just wanted it out. That's what made me choose made my decision. Yeah.
Now, who was responsible for swing? Was the fact that your brother had it, or was the fact that your doctor encouraged you to get it? What?
No, my doctor didn't encourage me to get it. Just like I said, I think the main thing was my brother just had it, and he seemed to be doing fine after he had it. So I think that was the reason I chose that. Once again, like I said, radiation wasn't a big discussion with me.
Okay.
The doctor really didn't discuss radiation that well with me.
Okay. Now, Dwayne, again, the question, how did you make your treatment decision with your doctor? And were you satisfied with the decision you and your doctor came up with?
Well, the first thing that my doctor told me was that that it was too far advanced, and that and they would not do surgery on me, and because it wouldn't do any good. And so for a whole year, I went and I was on hormone therapy, and they told me I would have to be on hormone therapy for the rest of my life because of the advanced nature of it. After about a year, my brother, who was also a physician, had talked to another guy, and he said, my brother called me, the doctor, and he said, Dwayne, this guy is saying that you need to have a prostatectomy and go ahead and get as much of it out as possible because you have a high load of the cancer in your system. So he said you should have an old-fashioned prostatectomy, take it out, and give your immune system a chance to fight it, what's left. And so they still refused to do the surgery. And so I actually left the hospital and went to a specialty surgery clinic. And that was in 2011. Went to a specialty surgery clinic where this guy specialized in these advanced cases, and he did the surgery. And I was very pleased with the fact that he went ahead and did the surgery. But he, you know, when he did the surgery, they also had to cut out all the erectile nerves and stuff like that. And I knew that I would be impotent unless I got a penile implant. And then shortly after that, I did radiation, but the PSA kept rising after the PSA. And then I moved to Missouri. When I got to Missouri, I met another doctor. And this doctor told me, he said, Dwayne, you need to take a holiday. And so all these other guys were saying, go hard, go hard, go hard. And he was glad that I took the surgery. But he said, you need to go have a holiday. And I've been practicing that now for 9 years, where I do 6 months of hormone therapy. And then I take 6 months off against the wishes and desires of my current doctor, because I feel so much better and it gives me that much time to recoup. But I had no idea. It was just a lot of YouTube searching, a lot of talking, and a pure stroke of luck or blessing that my brother was in the field and had some contacts. I believe that had I stayed with my first doctor, who was very well respected, a very respected institution, that I would not even be alive right now if I had not done the surgery and given my body a chance to fight it.
Okay, so I want to ask you a question. Earlier on, when you were on hormonal treatment, was your PSA elevated at the time?
Well, right after the surgery, it went down to like 0.015, and then 2 months after that, I had radiation treatment. And the first test that I had after first PSA after radiation treatment, which is about 2 months after radiation treatment, it was already back up to 1.3 or 1.4, and it was doubling every month and a half.
So is it elevated now?
Yes, it's I just came off of 12 months or 9 months of straight treatment, and I'm on a holiday right now, and it's going back up. It's right at about 2 now.
Okay, so now I want to ask Henry. Okay, Henry, and how did you make your treatment decision with your doctor? And were you satisfied with the decision you and your doctor made?
I got no support from the doctors. They didn't want to make any recommendation. They all said it's up to me what I wanted to do. So I had to do my research, and that's when I discovered the radiation and the brachy. Am I happy now? No, because the PSA went back up. I'm on androgen therapy now. I have no testosterone. I feel blah. And you know, as I think Dwayne said, thank God I'm alive, because if I hadn't done some of those things, but I wish I had more information from a doctor who was knowledgeable. Now my golf buddy went to Johns Hopkins in Baltimore, and he discovered a black doctor there who specialized in prostate cancer, and he's written books on it. And so he has done well with the treatment. He had radical prostatectomy, and I'm kind of jealous that maybe I should have gone to Johns Hopkins and met with people there.
Okay. I want to go on to the next question, and I'm going to circle back with some of the information. Tom, did you have a point?
Yeah. I would, if you don't mind, I would kind of like to bring up FinPath just to kind of show people where these gentlemen began their journey and where they are now. Is that okay with you? I know I'm kind of stepping in.
Yeah, no, I will pull it up. That's perfect timing.
Do you want me to do it or you got it? Okay.
Yeah, I have it right here.
Okay.
Okay, so again, everyone, this is finpath.com. This is what you'll see when you go to the landing page of the home page. And all you have to do is scroll down and take a look. You'll see the 5 categories that I talked about. Now, everyone here, we won't talk about initial prostate cancer. Tom, we want to focus at
I know. I'd love to actually go to the initial prostate cancer diagnosis.
Okay, let's go through that. So if we talking about, let's start with Dwayne. Dwayne, you had an elevated. So Tom, do you want me to go into a little bit more detail or just?
Well, what I think we just want to show is that where each one of these men were when they were diagnosed, and then the fact that they chose a treatment. I know that Dwayne, he was probably at high risk. I'm not sure whether he knew. Actually, he was a reasonable risk. He was right there.
Yeah. So now, so Dwayne, so in this case, at the time, we'd already identified, well, just from your history, we had already identified what your risk level was, because you'd already said you had evidence of prostate cancer in the regional areas. So now from there, if you go to Finn, now we're talking about your life expectancy. You were diagnosed at 46. So, and then at the time, because now you're depending on your treatment options, depending on how your life expectancy. In this case, you were obviously 46 and you were going to live another 33 years. So if that's the case, we would have come back. And so, so greater than 5 years with no symptoms, or 5 years or less and no symptoms, and then 5 years plus. Now you're falling into this category here. Now these at the time, instead of they're just starting you on hormonal therapy, there was the options of external beam radiation plus ADT at the time. Because you told me earlier, they just started you on hormonal treatment and did nothing else. Mm-hmm. And then again, they're showing here a combination of radiation and ADT, or just in this case, the groups elected and only didn't elected to use. I don't know if they used ADTs. I think there was just a normal, like Lupron. Was that what you were taking?
Just Lupron.
Yeah. So you were taking Lupron instead of some of the advanced ADTs like abiraterone or some of the fine particle abiraterones. And then the question is, and the point that I bring up, is another treatment option are clinical trials. So that's where at the time your diagnosis and the period of time where you're sitting around for 2 years, luckily having a brother who was a healthcare professional that pushed you along and to get additional information. But now,
but I want to just say one thing here, that Dwayne, you mentioned that they recommended against surgery. Surgery is not recommended at the stage that you were, according to the National Comprehensive Cancer Network and the treatment guidelines. But as Dr. Crawford pointed out, there were many other options other than just the ADT. But surgery is not one of the recommended course of treatment at that stage.
Okay, and so let's go to step back a little bit and go back again to the initial diagnosis, and then Sherman, you had mentioned that in your diagnosis, when you were initially diagnosed, your PSA had increased to about 4.1.
Yes, from my 2.5 to 4.1 in over a year. Yes.
Okay. And then did you even have any information, because this is something else we want to tell you, is that when you're understanding your risk level in the initial period, your initial diagnosis, you need to have information about your PSA, prostate specific antigen, your biopsy results, your Gleason score or grading group, and your cancer stage. And then what happens when you have this information, it can tell you where you are. Are you very low risk or low risk? And in this case, I don't know if you recall what your biopsy was, or did they do a biopsy?
Yes, they did a biopsy, but I can't recall what it was.
Okay. So, but one thing that was important, you had a PSA that was, and did anybody tell you anything about metastasis or bone involvement or outside? Did it go outside the prostate? Did they hear those terms?
When I had the surgery, no, it didn't say anything about going outside the prostate. You know, that wasn't. I mean, after I had the surgery, then they discovered it went outside the prostate.
Oh, after you did the surgery, so it had gone out. Okay, even
Yeah.
though you had a very low PSA.
Right.
Right. So in
Right.
that, so then initially, so if that's the case, if it had gone out, did it go outside in the tissue outside it, or was it attached to the bone or anything like that?
Oh, just the tissue outside, because they tried to do a nerve sparing surgery, but they found out that it was right in the tissue, right outside the prostate. Yes.
Okay. So now, again, you're falling into that category where you have your high risk disease and it's regional. And if we go back in a similar category, you were diagnosed in your 50s. So after seeing what happened with Dwayne, he was diagnosed 46. So, and that was 30 years. So you would have, your life expectancy was obviously going to be more than 5 years. So again,
Yeah.
what was interesting is, and this is something that Tom said, from the NCCN guidelines, these are the guidelines that they instruct doctors to use, that surgery was not part of that. And then there were obviously radiation and combinations of with other therapies, but at the time, it wasn't part of it.
Let me, I'd like to bring one point in here. And, you know, the reason that surgery is not one of the options here is because it's clear that surgery in all probability is not a cure. And if it's not a cure, surgery can cause you many harms without really curing the disease. When I was diagnosed, I chose not to have surgery and to go with a combination radiation treatment simply because it was determined that I was in the same category as Dwayne and with Sherman. So instead of having surgery that could cause me a lot of problems, I decided to have a combination radiation, the same as what Henry had. So those are factors. And again, I think we want to point out that all of that information is available on FinPath. So now I had to do many nights of study and a lot of work to find that information out. But it is all available at your fingertips on FinPath.
Right. And then that's what's so great about this. I mean, it's at your fingertips, and not just at your fingertips where you're sitting at home, but you have the ability to pull out your mobile phone, your cell phone, your smartphone, and sit right at the doctor's desk, and you guys can talk about what your options are. And then Henry, I wanted to go back to you. What was your so you elected to do radiation surgery, and you said your PSA was, did you recall what your PSA was?
Initially,
Yeah.
5.
So your PSA was 5.
It was under 2, and it jumped to 5.
It had jumped to 5. And then did you have a biopsy or anything like that?
Yes, it did.
And did they give you a Gleason score?
6.
So you had your PSA was 5.
Right.
The Gleason score was about 6. And so again,
on the record it says 3D 3 equals 6.
it equals 6. So, pardon?
Then it says
3 plus 3 is 6. Mm-hmm.
Then
Okay.
it says 11. Then it says 11B.
Okay. So now what we'll do is this. Again, we're walking, I brought you over to the understanding your risk level. So all the newly diagnosed people would move to understanding the risk level and make sure they have these 4 bits of information from their clinician. Now, so what do we know? Right now, we're looking at very low, low, and intermediate favorable areas. So let's look at low. Patients with an initial diagnosis of PSA less than 10, a Gleason of 6, and a group 1 cancer, and it involves 1/2 of one side of the prostate. So even in this case, you're falling in a category of low, very low, and it's very difficult to know where you are. But just say at the time you were diagnosed, and you said you were 65 when you were diagnosed.
55.
55. So you were diagnosed when you were 55. So now let's go back. Now that we know what your risk level is going to fall either very low or low, then we go back to the initial diagnosis page, and let's just take a look first at low risk. Now, again, we already have an idea that your life expectancy at 55 was going to be more than 30 years or more than 25. So we don't really have to go back there. But now, if it was less than 10 years, at the time, the NCCN guidelines are suggesting more of an observational watchful waiting. But in your case, your life expectancy was greater than 10 years. So you had a wide variety of options that were available. You had the active surveillance, you had external beam radiation therapy, brachytherapy, as well as radical prostatectomy. So because of your risk, you would have had the ability to either watch and wait, or, in your case, did you have external beam radiation or just?
Yes.
Okay, you had external beam radiation plus some okay.
Plus
and
brachy.
In brachy. And so you had external radiation in brachy, or some people were going with surgery. So you see what I'm talking about. Now, when you're looking at this, are you more comfortable with what your decision was?
Yes, and having heard Dwayne and Sherman, yes. And my friend who's still having issues after, 20 some odd years after his surgery. So yes, I am comfortable with it. I'm just disappointed that my PSA goes up and now I'm on androgen deprivation.
Right. I think what Henry is saying is that, yeah, he was categorized there as a low risk, but in reality, the combination treatment that he had was not curative. He was not cured, so
Right.
he had to go to another state. So I think it is, it's good now, Keith, if we could take a look at and find out on the current pathways where we are with each patient, where they are as they travel their treatment journey.
Okay,
Well,
so now,
if I can follow one thing that you mentioned, Tom. I transferred to a oncologist at Virginia Cancer Center, and he has told me that they do not have any treatment that's 100%.
Right.
And so that made me feel a little better.
Yeah.
But he also told me I can't have surgery. I shouldn't have surgery after the radiation.
Okay.
So
Okay.
that's a decision that was not told to me before. So I thought that if I had the radiation and that didn't work, I could go to surgery. But
okay, so now, and so we'll start with you, Henry. So
okay.
now let's see where you are. So that's where you started. Now this is where you are in your journey. So in your case, you've had radiation treatment, and then it's coming back. Your PSA is elevated. Is that what's happening?
Yes.
Okay, so now we're going to bring you to cancer progression after radiation. So we'll click on here. So now, again, your treatment options are going to be based upon, you know, biopsy positive with no metastasis or biopsy negative with no metastasis. So right now, what do you know about where you are in your journey as it relates to, were you biopsied again? Is there
No.
some metastasis?
No, I had bone scans and there was metastasis.
There was metastasis or no metastasis?
Yes, there was.
There was.
Yes, in my hip and my ribs.
Okay.
So that's when they put me on Lupron
Mm-hmm.
and Zometa. And it started, the PSA has gone up again. So in December, they put me on Zytiga.
Okay. So now that we've moved away, since we're talking about metastasis in relationship to your recurrence,
Right.
then we went to advanced hormone-sensitive cancer. So that's where that's the category that you fall right in right now. So now, since we know that it has metastasized, these represent the type of treatments that are available to you right now. Is there anything up there that you see that you're taking now?
Zytiga. I don't see the Lupron or the.
Yeah, the Lupron is ADT plus.
Plus.
So ADT means Lupron plus Zytiga.
Right.
Okay.
So you're falling in this category right here.
Okay.
Now, the other thing too that we want to bring to your attention is that you can always look for a clinical trial. And we're suggesting that everyone always be aware of the opportunities in participating in clinical trials, especially for African-American men. They don't have enough African-American men in enrollment. So they're continually looking to bring African-American men into clinical trials. What's so important about that? One, you're going to have cutting edge care, cutting edge technology. You're going to have more of a concierge-like medical care because they're going to make sure you get the best care because they want to see success, and it's going to be no cost. So that's where we are. So now if I go back up and we go back and I talked, Sherman, right
Yes.
now, where are you on your journey?
Right now, my PSA is 20.8. I'm on Lupron and abiraterone. About a year after I had my surgery, my PSA went up to 1.5. They put me on Casodex, and then probably another year and a half after that, they did some radiation. And I went from radiation to Lupron, and then in 2019, they just discovered that I had been metastasized into my chest. I have a few spots in my chest where I metastasized. And I've been taking abiraterone for over 7 years, but I'm at 20.8 on my PSA.
Okay. And so, and the, your treatment is, you're still hormone sensitive, your doctor's saying.
Right.
Okay.
Regarding the clinical trials, I talked to my oncologist no more than, I say, probably 6 weeks ago, looking for clinical trials. And so in my condition, that he couldn't find a clinical trial for me unless I've already gone through chemotherapy.
Okay. So I'm going to, what we could do is offline, these, if you go to our fight tool, these are some of the clinical trials that are available. So we're looking at castration biochemical recurrence, metastatic castration sensitive right here. And so there's one clinical trial that exists But what we can do is we can look online and see if there are other opportunities for you. So if we can call and get together, identify a time, and then we can talk and look for a clinical trial. Okay.
That would be great.
Okay. And then Dwayne, I said you're up on deck, and
Keith, can
yeah.
I just want to let the audience know that we will go to Q&A in just a few minutes. So if you have questions, you can submit your questions now, and we will go to the Q&A process with you. Thank you.
Okay. And Dwayne,
Yes.
so where are you now in your journey?
Well, 2 years ago, they found lesions in 7 different locations in bones in my hip, my ribs, femur, in my clavicle or shoulder, something like that. And then last year, last summer, after doing a treatment of Lupron for 6 months, and I got on a keto diet, it went away. They didn't see any evidence of any metastasis or anywhere in the bones. And but as a result, I decided to go ahead and continue the treatment, whereas I would normally just take off. And so I did another 3 months of treatment. And so I've been off of treatment now for probably about 4 months. Well, no, I started taking Casodex, and then I got off of treatment 3 months ago. So I've been without treatment for 3 months, and my PSA is right at a 2. And so I'll be due for more scans on April the 19th. But as it is right now, it seems to be somewhat under control, but it's rising slowly, and I'm off treatment.
Okay. So again, you've reached to a point where you had a diagnosis of metastasis or identified metastasis.
Yes.
So you're going to fall in that category of advanced hormone-sensitive cancers. And you had metastasis because you had recurrence after surgery and after radiation. And so you're at metastasis right now. And if we take a look at these therapies, so the only thing that you're on was more of the Lupron.
Yes.
Okay. And did any one of the doctors talk about combining ADT plus the
No,
or
only had a Lupron, and then of course I had a 3-month oral Casodex, and that's it. And that was not with Lupron. So I had Lupron for 9 years on and off, and then I did 3 months of Casodex because I told them I didn't want to do Lupron anymore. I just refused to do Lupron. So then they gave me Casodex as an alternative, and I didn't like that either. So I've got to make up my mind in terms of what I'll go from there. But I have not, these other Taxoteres, Zytiga, all of that, I've never got any of those recommended to me or anything.
Mm-hmm. Okay. And then we talked about clinical trials, I know in the past, and I don't know, have you had any feedback from the clinical trials in your area?
No, I've not, I've tried clinical trials for 10 years, and until I met with, you and Finn, I pretty much just given up on clinical trials. It's either that you're on treatment and you're not qualified, or you're not on treatment, so you're not qualified, or you had this treatment, so you're not qualified. And I just literally got tired of being told, no, you're just not qualified. And I thought that, and maybe my stuff was so aggressive that I was disqualified, but I've never in 10 years, and that's not for lack of trying, but never in 10 years have I ever been able to get a treatment and get a clinical trial invitation.
Yeah. And so then we have to go back to those 2 clinical trials in your area. One was for genetic testing, and the other one was a combination of genetic testing plus.
Yeah.
I think that you fell into that category because of that history of a documented history of metastasis.
Yeah. I'm still pursuing that, but I haven't been able to get in that.
Okay, so that's something that we need to press on also. So what, and I'll get ready for the Q&A session. But what we wanted to show here is, again, how the system works, how finpath.com works, and how easy it is to maneuver, whether it's initial diagnosis and now looking at where you are today along in your journey and where you will be, where you can potentially go. So thank you, gentlemen. And I'm going to switch over, and I think we have some Q&A that we want to move to, Tom.
Yes, we're waiting for the question from the audience. But I would like to add this to the panel discussion. Number one, I want to thank these men for coming forward and sharing their story. What you see is that a prostate cancer journey can last a lifetime. For me, it's lasted 21 years. And as you can see from these patients, it's last a long time. So it's all about trying to understand the best treatment options for you at the beginning, and then hopefully that you can be cured. If that's not the case, if you're on a long journey, such as I am and such as these men are, then it's about understanding what those options are as you continue along that journey. Now, we all are, as patients, we will be continuing and looking at FinPath and other treatment options down the line. And this is the reason that FinPath now is available to these men and to myself. So as we continue, we can find and understand those options quickly as we sit and talk with our doctor. But treatment options and treatments will determine whether you're cured, your quality of your life, and how long you live. So when you're initially diagnosed, there's nothing more critical than to find the most appropriate treatment. And as you continue along that journey, there's nothing more critical than to finding the appropriate treatments that are available to you. So I just want to bring this out. And so we have a couple of questions here. Do you want me to read those, Keith? So the first question is that a couple of the participants were considered low risk with a PSA of less than 10 when they had treatment and their cancer was already outside the prostate. Were there other circumstances that caused the spread so early? Who would like to answer that? Or were there other circumstances that caused the spread so early? I'm not sure the spread was that early. It just may not have been detected, upon the diagnosis. Were there other circumstances, Henry, in your case that you can think of?
No, I can't think of anything that was going on.
So Henry, did you have a biopsy though?
Yes.
Yes. And your biopsy was
6.
6.
Recent score is 6. The stage of 11.
Right.
The urologist felt that it was very aggressive. So that's why he rushed me into an option.
So maybe may have not have been a 6 if the way they described it.
Yeah, and maybe the pathology reading wasn't correct, and there are tests now.
Yes.
There are tests available that were not available at that time that can test the tissue samples to see whether that pathology reading is correct, or whether you actually belong in a higher category, or in some cases a lower category.
That's why I wish I had gone to a John Hopkins or another, not the local Alexandria hospital.
But it's important that people hear your story, because right now the technology that exists, at one time they're biopsying and they're showing how there are differences in the genetic makeup of the tissue of African-American men to other men. This is why it's very important for one, to participate in clinical trials, because we learn more and more about African-American men when it comes to what their tissue, genetic makeup on their tissue is. And we go back to one thing, and I leave that message of early detection screening. So starting out at 40, at least having the discussion at 40, because the earlier you detect it, the greater your survival.
Let me go to another question here.
Yeah.
I was recently diagnosed and have completed hyperfractionation for 28 treatments. My oncologist stated that he wanted to wait 6 months before my next PSA test. Do you find that timeline appropriate? I don't see a problem with a timeline of 6 months after that treatment. I think I don't see a problem with that. Next question, does it make sense to have a second opinion on biopsy pathology? I would answer that the tests that are available now, the number of tests that I mentioned before, you can certainly ask your doctor to look at tests that will confirm the pathology and whether your cancer may be more or less aggressive than what you see on the pathology reading. You can always ask for that test, and I would certainly recommend that test. How many of the panelists had a family history of prostate cancer?
Okay.
I did.
Okay.
I do.
You froze up a little bit.
My grandfather, both his sons died from prostate cancer. My first cousin died from prostate cancer. So, and I had the genetic testing done, and they didn't find the genes. So
Okay.
But
if I may speak,
go ahead.
if I may speak, yes, I have 2 brothers, a father and uncle, all had prostate cancer. And when I had to do the genetic testing as well, and they found nothing either.
And so what's going to be important, if there are now clinical trials where they're doing much more detailed, advanced genetic testing. So the earlier studies and some of the studies out there right now may not be as comprehensive as the ones that are being rolled out in clinical trials. So if at any given time, if someone wants to call, there are several clinical trials that are looking for Black men with metastatic disease, and they want to look at their genetic background. So
I'll be in touch.
okay.
All right. So I'm not a panelist, but I certainly had a family history of prostate cancer. I lost my father and both grandfathers to prostate cancer, and I have a number of uncles who had prostate cancer. Okay, those are the questions that we have. Okay, to the panelists, was there a time when you felt or was told everything was okay, that it's clear, and there was recurrence? Did you get the wrong message?
Well, in my case, in the very first beginning when I had surgery, yes, I was told that they had everything. And about a year later, that's when my PSA started to creep up again. And so, yeah, I was kind of devastated because I was thinking that they got it all. But, I was told later that sometime it can escape outside the prostate area. And that's when I first learned about the fact that it had escaped outside the prostate area.
Right, absolutely. Dwayne, what about you?
No, I was never told that I was in the clear, or that it was a low grade. So I always expected the worst. So
Okay.
Yeah, my doctor would never make a decision, a statement like that.
Okay.
We have an online question, Mr. Farrington, if you don't mind me reading it out for
Sure.
everyone. Okay. Brian Jarvis says, I was diagnosed with prostate cancer in April 2012, and I'm well along my journey. I will certainly utilize your FinPath website to gain additional information regarding my treatment options. Thank you for your efforts. This is very good information with each of these treatment options. Is there a page that shows the various side effects, quality of life impact of each treatment, and the probabilities of experiencing those side effects?
There is information on different treatments within FinPath, the different therapies. I think a lot of that information would be there. Yes.
Yeah, and if there's a need to call, we're here to help put together information for you. And then also, it's the tool works so when you have that discussion with your clinician, and your clinician can really go into a lot of details about, the impact. But what we do know is this, is as Black men are living longer and men with prostate cancer are living longer, it's now very important to keep track of their bone health also. So all of these, especially a lot of these chemotherapies, may directly impact the strength of your bones. And if you fracture your bones, then your quality of life can change also. So
Okay, we have a few more questions and we're going to take those. And first is, would you recommend taking a PSA test every 6 months after treatment? I got a PSA test every 6 months after treatment for years, and I continue to get a PSA test every 6 months. So that is my recommendation, although some of the doctors may say 1 year is okay, but I think, that's a good point. The earlier you catch recurrence, the more options you have.
Right.
So don't delay. Don't think because you had surgery or radiation that you can lay back and not have a PSA test. You do want to still monitor where you are with your with PSA tests. Another call, can you participate in a clinical trial if PSA is around 4 to 5? There are clinical trials out there that Dr. Crawford has pointed out for almost every case. So I don't think a PSA around 4 to 5 would prohibit your participation in itself, would limit participation in a clinical trial. Another question, what does everyone think is the age they would recommend screening? I can say that FIN recommends African-American men begin screening at the age of 40. We have just released another tool, finpsa.com, and you can find everything that you need to find in there about screening. Again, finpsa.com. It looks at all the different screening guidelines along with the recommendation that I just outlined.
and so I wanted to flag it again. African-American men are at high risk. African-American men with a family history are at high risk. And we're talking about starting to screen today if you're in your 40s, close to 50, but starting right now, if starting at 40 is where we're suggesting everybody start. I know that there's some people have asked questions and said that they're 49. The issue is, Tom said it, early detection, the broader your reference, the broader your options that are available to you. And early detection, the your 5-year survival, 10-year survival is close to 100%.
The next question, assuming active surveillance is a viable treatment for low risk, how can we get more information? Go FinPath has information about when active surveillance is a viable option for you. But then after, if you think it is, based upon your diagnosis, certainly you want to have that discussion with your doctor.
Mm.
And the doctor should provide how the active surveillance is conducted within their within the institution, and help you get on active surveillance if it's something that you would like to do.
Mhm. And then there were some more details about PSA number, and a lot of the information that people are asking are related to your biopsy. And so I can't really address the issue of metrics in relationship to your biopsy, but if you have any questions about that, we can help. I can help get that information to you. Just you can give us a call or email us, and we can help walk you through it.
I want to thank the audience for joining us tonight. This has been, we've been on now for about an hour and 15 minutes, and we'd like to try to do this during an hour period, but we had a lot of information. We really wanted to have these patients, we want to have Henry, Dwayne, and Sherman on tonight because they've been on long journeys. And there's so much information that can be gathered from their experiences. We will now go back in this webinar series and take a lot of time beginning with men who are initially diagnosed. We will look at understanding their risk level, and we will go through the treatment options for men newly diagnosed. As I pointed out earlier, that is so important. That is a period in a man's life when you're diagnosed with cancer, when you're very frightened. And right. We have information on FinPath, so we're going to take our time to walk through that process with you in future webinar sessions. So again, I want to thank everyone for joining us tonight. I want to please Dwayne, Henry, and Sherman, thank you so much for sharing your story. I think your story will help a lot of men. And we've been able to talk about your experiences and then follow you along FinPath. And Dr. Crawford, thank you so much for moderating and presenting on this topic. Now I do see other questions that are coming in. So let's take a quick look and see what we have left.
One of the questions was about side effects. And the one that distresses me the most is the hot flashes. I don't know if anybody else has them, but they come out of nowhere. I might be at a meeting or wherever, and all of a sudden I just start sweating and I'm hot. And that's from the Lupron shots.
Yeah. I do want to point out, because we've gotten a couple of questions, this program will be available on our Fan TV series, and you will it will be posted on our website within the week, but it will remain on our Fan TV series. So you will be able to access it there. That's fantv.com. All of our webinars are available on Fan Television. So again, thank you so much, gentlemen, and thank you for the audience. And I would like to say good night to all.
All right. Good night, everyone.
Good night.
Good night. Thank you. Thank you.
Thank you, gentlemen.
All right. Thank you. Good night.
Thank you.